audible to all? Am I audible to all?
Yes, ma'am. Hello.
Oh, hello. We still have 8 minutes to go, so we can wait.
तो कैमरा बंद कर दिया ना। कैमरा बंद कर दो जल्दी से। हेलो डॉक्टर पूजा।
हेलो, कैसी हैं आप?
ठीक हूँ, आप कैसे हो?
मैं ठीक हूँ।
बहुत बहुत बधाइयाँ भाई बेटे के लिए।
थैंक यू।
हाँ, बहुत ही
लाइफ
अच्छा है।
लाइफ टाइम अचीवमेंट अवार्ड है मेरा।
हाँ बिल्कुल। सारी जो है, सारी
हाँ,
शिकायतें और सब दूर हो गई इस बात से।
सब दूर हो गई।
नहीं तो वो हो जाता कि ध्यान नहीं दिया माँ ने।
हाँ 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 हाँ। स्कूल से 1 लाख रुपीज मिला है।
ओ, वेरी गुड।
हम्म।
बढ़िया।
आपके यहाँ नए जूनियर्स आ गए?
एक ने ज्वाइन किया था, बाकी तो सेकंड काउंसलिंग का वेट कर रहे थे। अभी तो तमिलनाडु में कुछ स्टे लग गया है।
अच्छा।
ऑफ तो 5 ने कर लिया था, लेकिन एक ने ज्वाइन किया, 4 वेट कर रहे थे अपग्रेडेशन का या जो भी वेट कर रहे हो।
अच्छा।
तो अभी तो फिलहाल तो मतलब अभी एक आध महीना लग जाएगा।
अच्छा, अभी भी
हम्म।
1 महीना?
हाँ स्टे है तो वो तो हियरिंग पे हियरिंग ही होती है।
हाँ, स्टे में तो है ही है खराब।
हम्म।
मिमी फ्री हो गई?
हाँ फ्री हो। इंटर्नशिप स्टार्ट हो गई सेकंड से।
अच्छा।
हाँ रिजल्ट आ गया उसमें।
अच्छा, आ गया रिजल्ट?
हाँ रिजल्ट आके वो
जल्दी
इंटर्नशिप।
आ गया रिजल्ट, अभी तो कहीं आया
हाँ
नहीं।
1 वीक में निकाल दिया उन्होंने।
ओ।
सेकंड से स्टार्ट कर दी इंटर्नशिप। अच्छा
हम्म।
है, जितनी जल्दी स्टार्ट हो उतनी जल्दी खत्म भी होगी।
हमारे तो अभी तो खत्म हुआ है लास्ट वीक एग्जाम।
हाँ ऐसे केजी में भी ऐसे ही चल रहा है। अभी
हम्म।
बस सब जगह चल ही रहा है, मतलब मुझे लगता है कि बाकी लोग जून में कर लेंगे स्टार्ट।
जून में हो जाएगी स्टार्ट।
हाँ।
पर यूनिवर्सिटी तो एक ही है, तो फिर ऐसा क्यों?
नहीं नहीं, यूनिवर्सिटी तो एरा तो सेपरेट यूनिवर्सिटी है।
एरा अलग यूनिवर्सिटी है?
हाँ अपनी यूनिवर्सिटी है।
ओके। सब ने अपनी अपनी अलग अलग बना रखी।
हाँ बस छोटी छोटी यूनिवर्सिटी, अपना नर्सिंग कॉलेज और ये वो करके। आपका
हम्म,
कैसा चल रहा है वहाँ TSPM?
ठीक है, टीएसएम। नॉट
ये
बैड।
से अच्छा। चलो।
बाकी तो सभी एक ही जैसे हैं, बट ठीक है।
वहाँ MD है?
हाँ, 8 8 सीट।
वो तो ये
8।
बराबर ही है हिंदुजा के ये आपका हिंद के बराबर।
हिंद के बराबर नहीं है, हिंद जितनी टीचिंग नहीं होती है।
नहीं
अभी
नहीं, सीट्स सीट्स आई थिंक कितनी थी ना?
सीट्स वहाँ 10 है।
10 थी।
हम्म।
हाँ, वो इतनी टीचिंग तो नहीं होगी वहाँ
नहीं,
अभी।
जितनी हिंदी टीचिंग हो रही थी ना,
हम्म।
तो मैंने बाहर निकल के रियलाइज किया वहाँ तो डिपार्टमेंट एज अ डिपार्टमेंट चल रहा था, मतलब
सर्विस डिपार्टमेंट टाइप।
पूरा बकायदा डिपार्टमेंट की तरह चल रहा था।
हिंद में ना?
हाँ।
हाँ, यहाँ पे सर्विस डिपार्टमेंट की तरह चल
यहाँ
रहा
पे
है।
बस है सब कुछ, लेकिन
हम्म।
उतना एफिशिएंटली नहीं चल रहा है। आई थिंक एरा में
हाँ,
ज्यादा अच्छा चलता है।
एरा में तो मेरे ख्याल से बेस्ट है।
हाँ,
एरा
जेबा आई
की।
है ना, जेबा बताएगी। जेबा ने ज्वाइन।
अच्छा, जेवन। डॉक्टर जेवा ने ज्वाइन किया है।
हाँ।
हम्म,
बट एरा में आई थिंक टीचिंग है, उसके अलावा बाकी
एरा
पता
जितनी, हाँ, एरा जितनी स्ट्रिक्टनेस और टीचिंग कहीं नहीं
नहीं
है
है।
मेरे ख्याल से
नहीं है,
प्राइवेट
नहीं, यहाँ
में।
पे हो रही थी बट अभी यहाँ
हम्म
डिस्टर्ब हो गया, तो
हम्म हम्म हम्म।
पता नहीं,
अब
देखिए।
काफी सारे लोगों ने छोड़ा है आपके यहाँ से। उस दिन नीरा कोहली मैडम आई थी तो कह रही थी
उ-
जाने कितने
उन्होंने भी
16।
छोड़ दिया।
नहीं, उन्होंने नहीं छोड़ा, उनको क्या पड़ी है। अभी
हाँ।
75 के होने के बाद तो उनको मिलेगा भी नहीं ना कहीं। 70, सॉरी, 70 के बाद।
अच्छा।
हम्म।
हाँ।
तो वो कह रही थी 16 या कुछ लोगों ने छोड़ा है।
नहीं, अभी दो और छोड़ गए कल।
अच्छा। खाली हो
पुरानी
जाए।
पुरानी फैकल्टी, मतलब ऐसा नहीं कि।
हाँ, ये नए ज्वाइन करेंगे फिर पुराने छोड़ देंगे।
बर्गर। आई थिंक 1 मिनट मोर बिफोर वी स्टार्ट। मैं कोशिश कर रही हूँ उसी साकिर की सीवी डाउनलोड हो जाए, वो ही नहीं हो रही
अच्छा
है।
अच्छा अच्छा।
अब हुई है, अब जाके डाउनलोड
हो
हुई है।
गई ना?
हाँ। खैर, साकिर को सीवी की जरूरत नहीं है, लेकिन
फिर भी
हाँ।
कस्टमर ही है।
हाँ। हाँ। Okay, so we are here to start. It's 8:30, and how do I allow you to share the screen, Sakir? You will need to help me out. I don't know. Some I'm not being able to do that.
I've sent you a request.
You have sent me a request where, okay, okay, yes, I've allowed.
Thank you.
But let
So,
me show your CV first. Let me open your CV. There's some problem with my laptop today. Seems. Yeah. Okay. So good evening, everybody. So we are here again with our next session of So Reconnect, and the last topic we had was on AI, on AI, use of AI in clinical osteoarthritis, and today we'll be talking on AI, role of AI in OA research. And now, why this topic is important? The reason being that at present, the quantum of patients with osteoarthritis is increasing.
Time.
We don't know about the what type of research we have ongoing in India. So probably if we start using AI, we'll get something more as to what type of research is ongoing and what we can do to improve it. We did a small trial with the help of Sakir, and there are 4 or 5 of us, and we did some small research where Sakir taught us how to use uh, how to basically look for papers on osteoarthritis in India. And this paper is already submitted in JAPI. I think it will be out in 3 4 months time. As such, he does not require any introduction, but still it's a meeting, so I have to introduce him formally. So Dr. Sakir is a professor in rheumatology and clinical immunology in KIMS Bhubaneswar, and he's a great academician, and he's editor in chief in immunological research, and the chair of Asia APLAR SIG for digital health and telemedicine. He's a convener of IRA SIG for digital health. So he's very active in this uh, AI part in different aspects. Lot of publications he has. So I won't be taking much of time, and we request Sakir to begin with his presentation.
Thank you, ma'am. Good evening, everyone. My thanks first to Kiran ma'am and Pooja ma'am and the entire SOAR family for having me here for this talk. So, first disclaimer, I'm not AI guy. I'm obviously a rheumatologist like most of you. And my interest is there, obviously, uh, in osteoarthritis as well as AI. My job was made easier by Kunal because he has already told you what is AI, what we need to expect from it. So I'm just sharing my screen and I'll start my slide. Sorry for that. I think my slide should be visible now.
Yes.
So what I was told to talk about was something more about deep learning. And I'll start just where Kunal has left off. So a disclaimer here, this is a little bit advanced. I hope everyone will be on the page. And if anyone has any doubts, please feel to interrupt me, or you can ask me at the end. Obviously, we are not the AI people. Some of these concepts will take some time to understand, but I'll try to show you what my work I have done. Some of these may not be in osteoarthritis as such, but we can use the same concepts and apply them even for OA research. So what Kunal had told around 1 month back, I have taken his permission to share his slide that people think that AI is going to be useful for clinical decision making, medical question answering, but actually it is much more useful for administrative purpose. Who needs to park their car nearer to the hospital and who gets the priority parking slot? Which patients are to be prioritized to be seen first and which patient the hospital is going to make money from? That is where actually AI is working, but in other things such as translations, academic writing, because we are not English writers, so our English may be sometimes faulty, and we can always put it in a AI system and we can get it corrected. It is always preferable when you do that, you should tell the journal that this has been corrected with the help of XYZ AI. So where it is practically useful, if your EMR is bad, I think most of us who have used EMRs, we know that most of the EMRs we use are bad, and it's not just in India. I have friends across the world, everyone complains about their EMR. So where the EMR is bad, that is why AI can help you. You can just dictate something in normal language and it will help you kill the EMR. And as I have mentioned, operations like prioritizing patients, prioritizing for surgeries, which patient needs to go for uh, knee replacement surgery vis-a-vis who can be better managed with conservative surgery. So this is where actually AI is helping at the current scenario. Documentation and insurance, especially in US and all, you'll have 50 codes for osteoarthritis, which is the most appropriate code, which is going to be useful for the hospital. So there used to be teams of people doing that. Now these teams are gradually being replaced by AI. And obviously, the notes we take, we can take a voice note, we can convert it, we can summarize it, we can summarize 20 years of history within 2 minutes and get a very brief outline that what has been the major event in the life of the patient. And obviously, patient education. We can see lots of people for in last month, April was Rheumatology Awareness Week, Rheumatology Awareness Month, and various rheumatologists across the country were using AI to generate various educational material which they were sharing with the lay public. So this is where AI has actually played a very good role. And where is it going to help next? It is something like when you have three-dimensional data, where for remote monitoring. Classical example of 3D data is the cartilage volume. Till now, people have tried various ways to estimate the cartilage, suppose in the osteoarthritis of the knee. But with AI, you can do it in a very um, elaborate or very scientific method. Then we have all the remote monitoring, like we wear smartwatches. So how much a patient is walking? You're giving any therapy for osteoarthritis. Before the therapy and after the therapy, how much walking is he doing? What is his basal metabolic rate? What is his heart rate? How much of activity he is getting? All this can be measured and analysis can be made by AI rather than trying to make sense of all this big data by yourself. What I commonly see in these forums is people say that AI is very good for diagnosis, but AI can never replace the love, the empathy that a doctor shows to the patient. So patients will always prefer doctors. But here I would say things are actually the opposite. If the patient doesn't know that they are talking to a AI, the people have done RCTs and they have shown that you use a AI, you use a doctor, let the patient chat, and if the patient doesn't know who is behind the screen, patients always prefer the AI. AI knows how to keep you happy. That is why AI is here to stay, and they will take much more elaborate, much more empathic history, and you can cope and you can have a rapport with the AI better than possibly with the doctors, because doctors will have fatigue and experienced doctors, they will find out your symptoms after talking to you for 30 seconds. But the AI will keep on talking with you for 5 minutes, 10 minutes, and it will give you that solace that someone is listening to me. So not what I feel, what has been shown is that AI is actually more empathic. And at the current stage, AI is not good for diagnosis. It can give you a pointer in a difficult situation. The clinical decision support systems are not practically useful. However, if you want AI to collect history for you, keep the patient happy, please go for it. So what am I going to do today? I'll just explain some of the terms used by Kunal. Though I could not attend his talk in real time, I have gone through the recording and he has talked about deep learning, natural language processing, large language models. So whatever words he has used, I'll try to explain them in simple concepts. I'll give the concepts and I'll just show where I have used this, how I have learned this. So first is obviously the theme of today's meeting, deep learning. What is deep learning? Is it some learning under the ground? But before that, let us come to transformers. Now, what are hidden transformers? In India, you see transformers all around. None of them are hidden. They are very much exposed to the public. If you go to Hollywood, Hollywood have transformers. These are basically robots who disguise themselves as cars. But what exactly are these hidden transformers? But before going to that, let us talk about what is intelligence. Intelligence has been, there are many definitions, but mostly intelligence has to be self-aware. I am there for I exist. There has to be abstraction. So beyond the data, something new should be there, which should help in problem solving. So what I feel the most important thing for intelligence is adaptation. You have an environment, you get information from the environment, and you have a way to adapt to that. That is what I feel is actual intelligence. So the question is, when will you call a machine to be intelligent? When it can play a game, when it can break a code. These are very historical examples. Initially, people, when they saw calculators, they thought that people would lose the ability to do mathematics. Then a person named Charles Babbage, what they did, he discovered an engine called the difference engine, which can solve polynomials. You know, quadratic equations you can solve, b plus bracket over 4ac minus ab. So all that formulas are there. That is for quadratic equation. But what about the equation with x to the power 3, x to the power 4? So वो admit करके लगेगा या normally लगेगा जैसे ये लगा है normally लगेगा so what Charles Babbage did was he made a machine which will find out the real solutions. Obviously, some of these have imaginary solutions, but I'll not go into mathematics. And this was a breakthrough. Then people said, no, a machine cannot break a code. You can make a new code, and how will the machine know what a new code is? But if you have seen one movie about the Second World War, this is the machine called Enigma. So what Enigma has done, it was used to break the German codes, which ultimately enabled the Allied forces to win the war. The name of the movie, if you know,
What is
excuse me, that is the Imitation Game. And the person behind this was Alan Turing. So Alan Turing is also considered one of the fathers for artificial intelligence, and he was played by Benedict Cumberbatch in the movie. Then people said, okay, it has broken a code, but it can never play a game such as chess. But we all know the story, what has happened. Back in 1998, there was one computer called Deep Blue
that?
made by IBM, which ultimately defeated the then Grandmaster Gary Kasparov. And since then, even our mobiles are so powerful that your mobile will be able to defeat most of you in chess. So, what Google did, Google developed a artificial intelligence called AlphaZero. Whereas what the most common chess engine you have on your phones is Stockfish, or even on the internet, that is Stockfish. Stockfish has been taught all the chess games played in last 300 years. So it has learned from human chess games, but this AlphaZero has taught itself. It has played against itself and found out the best strategy. And when Google first launched AlphaZero, there was a match between Stockfish versus AlphaZero, and Stockfish won 0 games, and Zero won around 13. So ultimately, AlphaZero defeated Stockfish. Then again, people trained it further. So the next version of Stockfish ultimately defeated AlphaZero. So AlphaZero is something which was unsupervised, whereas Stockfish is supervised learning. Let us understand what we mean by these concepts. So very basically, artificial intelligence is the overall concepts where a machine is using intelligence. One part of artificial intelligence is machine learning. And Out of the entire domain of machine learning, the central part is deep learning. What is machine learning? It is the study of programs that can improve their performance on a given task automatically. You give them a task, the more it does the task, it keeps on improving itself. That is the definition of machine learning. When it does, it improves. Machine learning, basically, we can divide into three types: unsupervised, supervised, and reinforced. So, what exactly is supervised learning? Very simple. You show a model, these are apples. Apple looks like this. So you show them 1000 pictures of apples. Then you show them various fruits, and it will just classify that this is an apple, this is a definite apple, this may be an apple, and this is not an apple. So in the context of rheumatology, suppose you take 100 X-rays, and each of the 100 X-rays you annotate, this is a joint, this is a joint. So when it has seen 100 X-rays with 24 joints each, you can, the next time you put an X-ray, it will automatically pick up this is the joint space. So this is called supervised learning. And what exactly is unsupervised learning? Or um, so as I said, supervised learning, you tell these are apples, these are apples, these are apples 1000 times, then it should be able to separate apples from bananas. In unsupervised learning, it is like you give them a mixture of apples and oranges, and you tell the machine you separate by yourself. What the machine does, it will take one, it will keep it in basket one, then it will pick up the second fruit. If the second fruit feels like the first one, it will keep it in the same basket. If it feels somewhat different, it will keep in the second basket. Then again, third one, it will again decide this third one is more like the first one or more like the second one, and then it will keep on separating. So this separation is there, and then ultimately you see in basket one how many are oranges, and in basket two how many are actually apples. So this is called unsupervised learning. So as I have said, the supervised learning was Stockfish, which was taught 300 years of chess history, while AlphaZero was unsupervised. So in the games played, AlphaZero won 28 of the games, while Stockfish 8 won none. But then the next version of Stockfish came. Now even Stockfish 15 is available. So Stockfish 15 has defeated AlphaZero. So what is the main issue with supervised learning is that you need to label. You need to tell this is a joint, this is a joint, this is an apple, this is an apple. So many times we can see many websites will ask us, you mark where is the bicycle, you mark which is the traffic light. So every time we are doing that, we are not just passing the test, but we are also helping them train their AI systems. Google is using that so that everyone who will mark the traffic light, the AI is being taught how to identify the traffic light in the picture. So this is how many of the companies are tricking us into training their models. Again, supervised learning is two types: classification and regression. Again, I'll say very mota mota. Classification is for quantitative, apples and oranges. Regression is when it is continuous. You know that the market is going down. What is the Sensex going to be tomorrow? When it is continuous data, you use regression, and when you need to separate two different things, you use classifications. Again, regression, classically, we know two types of regression we are using in our stats. When we publish paper, we talk of linear regression and we talk of logistic regression. But if you talk to a mathematician, they will tell you so many different types. There is polynomial, vector support, random forest, so many different types basing on the type of distribution of data. Your data may have a binomial distribution, it may have a Poisson distribution, it may have a log normal distribution, and depending on the type of distribution of your data, you need to apply different types of regression. And that also is a kind of machine learning. Coming to um, classification. Classification, very easily we can understand with the help of a decision tree. So even in clinical, we have some like the detect questionnaire or pulmonary hypertension screening in systemic sclerosis. Similarly, we can have decision trees. What is the age? If the age is less than this, you look at weight. If the age is less than 18, then there is no issue, low risk is low. If age is more than 30, you see whether the person is a smoker or non-smoker. So ultimately, depending on different nodes, suppose the age, the weight, whether there is a smoker, you'll ultimately get whether the person is coming in a low risk category or a high risk category. So this is a very simple decision tree, and you have nodes which will tell you ultimately give you the output low risk versus high risk. This is a very simplified classifier, and we can keep on making it complicated. When the numbers are much more, the branches here we can see one branch, two branch, three branches. But when the number of branches are very high, we can use probability sampling, and then we call it a random forest because we are not measuring each branch. We are just taking probabilistic samples and finding out which is the most likely branch, which is likely to be correct. And when your tree looks something like this, you use lot of algorithms, then it is called extreme gradient boosting. So you can look at the, if you are interested, you can go into details. But for simplicity's sake, you just think of it as a very complicated tree. And from the trunk, you need to reach one branch. And this is required when you have very much different outcomes in the classification. Another is k nearest neighbor. So nearest neighbor is you measure the distance or the similarity between the first element and the second element. Then you find the distance with the next element, and so on and so forth. Ultimately, you can classify them whether which samples are similar and which samples are not. Even if you don't understand the mathematics behind this, these are just the concepts. I'll show an example of support vector machine. But this, what I have talked about so far, is a case of all this have been supervised learning. Another thing is reinforcement learning. What is reinforcement learning? When you make a correct decision, your learning is improved. And whenever you make a wrong decision, you make a wrong classification, your algorithm is made to change. This is very classically explained by the Indian mother. So whenever you do something wrong, you'll get the belna or whatever. If it is, if you are nearby, you'll get the belna. If you are far off, you may get a chappal also. So we know our teachers, our parents have been scolding us, they have been beating us. That is why I am where I am. Whatever I am is because of they have spent their energy on me. And that is a type of reinforcement learning. When I do bad, they will punish me. When I do something good, they will encourage me. So this is basically what we call enforcement learning. Then coming to deep learning. So classically, deep learning is supervised, but it can be unsupervised also. The classic example of deep learning is a neural network. Where do you find a neural network? Obviously, in the brain. If you remember your physiology classes, the visual cortex will have 17 layers. And once the signal, the light falls on the retina, it is processed through the optic chiasm, the optic radiation, and it goes to the primary visual cortex. In the primary visual cortex only, there are 17 levels of neurons. And what goes from one layer to the second layer, no one knows. One knows how. The first layer will tell that these are the points. Somewhere, secondary visual cortex will know edges and lines. But how these points become lines and how these lines are actually recognized as face. Oh, this is Pooja ma'am, this is Kiran ma'am. That exactly no one knows. But that processing goes across 17 layers of neurons. But what we could not understand, the computer science people have understood and they have used it. So what they have done is that they have used these computer nodes You have an input, and from input it goes to layer one, from layer one to layer two, layer three, and ultimately output comes out. But what is happening? How the data is being processed from the visual cortex 1 to visual cortex 2? How the light signal on your retina is interpreted as a face? Exactly, we do not understand. That is why these are called the hidden layers. And what I was talking of at the beginning, I was talking of as of a hidden transformer. So these layers, which takes the input and transforms it to an output, is a hidden transformer. Where have you heard of a transformer before? I think all of us know ChatGPT. What is GPT? GPT is a generalized pre-trained transformer. So what is the transformer? That is actually the hidden layer which will, on taking the input, will give the output. And since it is pre-trained, all the data from the internet was put into it and it was trained. Okay, from this input, you show this output. And even if you give some novel input now, it can give you corresponding novel output. So ChatGPT, if you remember, is generalized pre-trained transformer. I hope it is clear what is a transformer. Obviously, we don't know how it works, but what is a transformer? What is a hidden transformer? Then another clinical example, let us say you have the data, you put the data that this patient, this is a male patient, 60-year-old, rheumatoid factor is this much, ESR is this much, CRP is this much, hair color is this much. And all this information will go into layer one. And the layer one will screen out. Hair color may not be important for the diagnosis. So hair color may be left out. And from the other something, it will go to the layer two. Layer two, it will go to layer three, four, whatever, whatever. And ultimately, it will give a output that this patient is likely to have rheumatoid arthritis or not likely to have rheumatoid arthritis. But what signal is going from layer one to layer two, from layer two to layer three is not exactly known. But the neurons talk to each other. It's like I know a guy who knows a guy. We don't know who is going to do the actual work, but the message passes on and ultimately the work gets done. So this is traditionally called a black box model because you're putting in data and you're getting it output. Now people are trying to go for explainable AI. They are trying to decompose this and find out what exactly is going out in the black box, and that is called explainable AI. That again is a big chapter in itself. So I'll show you some examples. Most commonly, I think in medical sciences, computer vision is being used. Computer vision is used mostly in for brain imaging for CT of the thorax, and obviously we are going to in a osteoarthritis setting. It makes maximum sense to use it to map the cartilage volume. What we have done so far is okay. This is gut microbiota. So what we had data 50 patients, we had the gut microbiota 55 patients, and we followed them up for 3 months. We could complete follow-up of 29 patients. Approximately half of them had chronic arthritis and half of them had drug-free remissions. And when we try to distinguish 14 from 15, the numbers are too small. But for each of these, we have GBs of data. There are thousands of microbiota for each patient. So how do we distinguish? We use something called, we use a support type of machine learning that is called support vector machine. So whatever data we had, we kept 70% as a training set, and we try to validate the results in the remaining 30%. So what is this support vector? These are suppose patients who have resolved, these are patients who have not resolved, or vice versa. We will try to draw a line which separates both of them. And this line obviously is a mathematical, line can be mathematical. If we convert it into 3 dimension, the line becomes a plane. So instead of a equation for a line, we'll use a equation for a plane. Similarly, we can go into n dimensions. If you want 3 dimension, 4 dimension, 5 dimension, mathematically, It is difficult for our minds to grasp. We cannot visualize 4 dimension, 5 dimensions, but mathematically it can be done by the computer. So it will choose which is the optimum line. Here we can see there are 3 lines. Out of these 3 lines, which line is separating the two samples maximum? So this is called a support vector machine. We use a support vector machine. We showed it was not working that well in 2 dimensions. It was better in 3 dimensions. But again, when we went to 4 dimensions, the uh, model worsened. And the best model included B27, use of drugs, methotrexate and sulfasalazine, and two specific families, Enterobacteriaceae and Bifidobacteriaceae. Accuracy was good, and we could identify various genera. So if these green ones were present, they would more likely the patient would go into drug-free remission, while these red ones were present, like Provotella. If they are present, then the patient is more likely to grow into chronic reactive arthritis. So this is one example where we have used type of machine learning called support vector machine. This was presented at ACR. Our student Prakashini, she was a student there, now more of a colleague. I presented this at Aplar, and Danda sir actually received the award on my behalf. That was 2023, before we lost him. And that was one example. Coming to the second example, where we have used artificial intelligence for predicting risk of infections. We will feed the CT thorax pictures into the model, and looking at the amount of fibrosis in CTD-ILD, it will predict who are likely to have infections. So we have left out rheumatoid because rheumatoid ILD infection risk is not so much. We have taken I'll show you the data, but basic concept is that we'll take some clinical data like age, sex, disease duration, and we'll put it in a classical neural network. Neural network, you remember, this will go input, and through the hidden layers, it will give one output. Then we would also take the imaging data and we will put it in a convoluted neural network. What is a convoluted neural network? In a classical neural network, the relationship between two variables doesn't matter. But when we say convoluted, means our brain we know is convoluted. The some of the neurons are closer to each other, some are far harder, because the brain surface is not very straight. It is curved. You have so many sulci and gyri. So that convolution enables some neurons to be closer to each other, while some neurons are are distant. So what a convoluted neural network does is that it will not only look at the pixel in isolation, but it will also look at the relationship of one pixel with the next pixel. So when you're trying to process an image such as the lung imaging, it is not just fibrosis at one point. What is next to that point? Is the fibrosis in the bronchus? Is the fibrosis is in the pleural layer? So that this is what a convoluted neural network does. So we the machine itself takes up. We don't tell the machine what to take up. It will take up by itself, and it will analyze on its own, include the clinical data in somewhere in between the neural network. It will process and it will give us a tangible output that this is the going to be the risk of infection for this patient. So basically, we had around 31 patients with systemic sclerosis and IPF, MCTD, dermatomyositis, Sjogren's, and they were on various drugs. And we used 45 of these for training and 5 for validation. And we changed. First, 145 was used, then on next 45, then next 45, and this kept on changing. And ultimately, the accuracy, internal accuracy, came to almost 97, 98%. And when we ran it, we would get something like this. We can see in patient one, if we give azathioprine, if we give cyclo-IVIG, it looks almost similar. The infection risk is around 30% at the beginning, then comes down as time goes by. This initial high may be because at that time patient is also on some steroids. But if you look at patient 5, it is a completely different picture. Initially, the infection risk is less, but as time goes by, infection risk increases. So what we saw overall was that for each one patient, the effect of drug was not so much. With some drug, maybe slightly higher, maybe slightly more. But overall, independent of the drug usage, the risk was more or less similar. But if we try to compare between patients, it was all over the place. Four patients with azathioprine have very less risk, practically zero. But other patients with azathioprine are having almost 20% risk of developing a pulmonary infection or pneumonia. So if we can see it is not the drug effect, but something else, the fibrosis, the muscle weakness, the frailty, ultimately, which is leading to the risk of infection. Then we tried to develop a system for a clinical decision of support, basically for diagnosis. All this work was done in a self-developed model. But what has happened is now LLMs are so powerful that we are using LLMs only. The best model which we will train will not be better than the currently available LLMs. So this was called SARA, Screening Agent for Rheumatoid Arthritis. I'll not go into details, but we collected, uh, I think, 380 patients data, and patient put in all the data in a chat box. There was just a question like a chat box, and patient would be asked a question, patient will reply in the chat box. Then this diagram was there, patient will mark where the pain, which joints or which areas joint pain is occurring. And we fed it into different agentic workflows. So we can have just single agent,
Hello.
or we can have two agents. One will just screen and the other will confirm the diagnosis, or we can have three agents. So one will analyze, one will give the diagnosis, and one will review whether the diagnosis is correct or not. So, sorry. The various, we use Gemini, we use GPT-4, we use even a couple of Chinese models, 2N2 and DeepSeek and Llama Trip. And they perform like this. The accuracy was not bad, 70%, 80%, depending on the agentic workflow we use. But what we are more interested is that even if the diagnosis was correct, what was the reason given for the diagnosis? So all the AI gave the reasons, and two of our fellows, they sat down and they validated the responses, whether the um, responses given are correct or not. So if we can see, almost approximately half of them were correct, but some of them, like mm, Gemini, you can see Gemini was doing quite well. But DeepSeek, the initial models, there was 50% of them were giving the wrong reason. Even if the diagnosis was correct, it was saying that person has no early morning sickness, that is why it is rheumatoid arthritis. So this, it was contrary to what we expected. We are trying to publish this. Another thing we have done is we are trying to detect rheumatoid arthritis from hand photographs. Similar thing can also be done for osteoarthritis. And osteoarthritis, you just upload a photo and we'll try to find out whether the person has rheumatoid or not. Again, I'll not go into details. We can take the photo of the patient. Then there will be a classifier. First, it will pick up which are the joint spaces. In the joint spaces, it sees if there is a swelling, if there is a deformity, or if there is any hyperpigmentation or skin changes. And it will take these three and ultimately give a conclusion. So these 380 hands were not 380 into 2, because both hands were there. This was taken, and out of them, actually 330 were rheumatoid and 64 were patients with fibromyalgia. And overall, it was not that great. We are trying to improve the model. Hopefully, once we have a better model, we'll go for publication. Uh, so, as I have mentioned, there are different things. You can use the whole image. You can use something like logistic regression. Then I showed you the classifier. XG boost. So different types of classifiers we have used for prediction. Then we have used rule based that at least two joints should have these things. Then you call it rheumatoid. So various combos we are trying, and we are trying to recruit more active patients with rheumatoid. And maybe if we can have some clinical information. And obviously, we need more controls. If you see 330 are rheumatoid, whereas only 60 are not rheumatoid. So we'll increase the number of normal hands or patients with fibromyalgia, include some clinical information like early morning stiffness, pain improves with rest or not, and then we'll try to retrain the model. So what I want to focus here is number one, the AI, what we are talking of, traditional AI, just advanced statistics, the support vector machine or logistic regression, what we have talked about. Only neural network is something which is inspired by the human brains. And to tell the truth, no one is knowing how the brain is processing. Similarly, the artificial neural networks also no one knows what goes inside in the hidden layers. And all the large language models that we are talking of, the large language models are all transformer based. Transformer is just a kind of algorithm which tells the neural net how to behave. There are other models like diffusion models, but again, I'll not go into that now. The future is not to train new models, but so many models are there. You have to find out which model works best for you. A different model may be good for image processing, different model may be good for taking history, different model may be good for summarizing the history. And if we use a different model for three different things, these three models should talk to each other. And basically that is called agent. You tell one agent, you call it agent one is good, it will take in taking history, so it will have a chatbot interface with the patient. It will take the information and it will give to agent 2. Now agent 2 is good at diagnosis, so it will compile all the information, but if it has a doubt, it will tell agent 3, give me the information from the x-ray of the patient. So agent 3 will is a vision expert. It will analyze the X-ray and it will say, there are erosion, there is possible seagull sign, and it will again send the information back to agent 2. So agent 2 will again process the information it has got from agent 1, agent 3, and it will give, so this is likely to be, this is 90% likely to be handoved. Then there will be a reviewer agent. The reviewer agent will see whether the information from agent 1 and 3 is supporting the diagnosis from agent 3. Then only it will release the report to the doctor. And obviously, that still black box is there. Now people are also trying to have that explainable AI. It will not only give the diagnosis that yes, endo is there, but what are the points in favor that the AI has declared this to be explainable AI. So that is all I have for today. Please don't ask me very difficult questions. I have average intelligence only. I'm not an artificial intelligence. So back to you, ma'am.
So, so it, so we won't ask you difficult questions because it was very difficult for us to understand also, and it was though brilliant. And any questions from anybody? I don't see, except for a comment from Dr. Shabi that it was brilliant. Yes, it was brilliant. Because we are not very well versed in this AI part, and probably uh, still lot of things were there which I could not understand. I do not know about others. So I request, if anybody has any questions, you can ask Sakir.
Not a
What?
question, but just a comment. And like it was uh,
really simplified. This is for the first time probably that I was able to really understand a few terms. And now I feel yes, I am getting the feel of it. So yeah, that was a wonderful presentation. So I can thank you so much.
Thank you, ma'am. So I
Hmm.
it was never easy for me also, but since I have worked on it, am compelled to learn these concepts and I try to present it in the simplest way possible. Obviously, if I try to explain XG boost, 90% of people will not understand. I'll also not understand. But once we start doing it, things we see the concepts over and over again, maybe it becomes more simpler.
Yes, that's true. We need to do it again and again to learn. And I think Dr. Amresh Kumar Singh has raised his hand. So, do you want to ask anything?
Yeah, hello, hi Sakir. It was a nice talk.
Thank you, sir.
Okay, I'm not a clinician, but I'm a fundamental scientist. So how these information can be utilized in case of like fundamental studies? Because whatever you're talking based on the data available. So if somebody has to apply your approach in case of fundamental understanding of the etiology of the disease and all, then how it will be useful? Like in which way we could apply?
Great question, sir. So, as I have said, initial part, what I had done is the metagenomics. We have the gut microbiota data, and gut microbiota, as you will know, there will be thousands of gut microbiota for each person. So that is what we call big data. So for analysis of big data, AI will help. As I again, I'm repeating myself, AI is basically a very strong statistical tool. Once we give them good information that and we try to ask them for a specific output, then it will give us the correct output. If the data is bad, if the question is bad, the output is going to be bad. What we call GIGO, garbage in, garbage out. And
So it means like with the like information or with the question, you need data also, right?
yeah, the most important thing what I
Okay.
feel in today's world is good data. If your data is bad, your model cannot give you the correct answer. However good the
Hmm.
model is, it cannot be better than the data you supplied. And the second thing is what questions you are asking, how you are asking the model to behave. That is entirely that part you can change. So for a basic,
Right.
very basic thing, you may know of systems biology. So you can get for a person transcriptomics data, you can get genomics data, you can get even methylomics data, and
Hmm.
we don't have exact manner to look beyond the layers. So one is the
What
DNA
about
express,
the preclinical data?
and that is what it may be clinical or preclinical. Suppose you are doing an experiment in a
Okay.
mouse model. So mouse, you have the genetic data, then you have the transcriptomics
Hmm.
data. Suppose you are doing a osteoarthritis model, you take synovial fluid. In the synovial fluid, you look at the metabolomics. Again,
Hmm.
metabolomics, you do a LCMS, you will get thousands of metabolites. So how will you
True.
understand thousands of metabolites? You will need advanced statistical approaches. That is where AI is applicable. And
So
not just
you'll
one
be
layer.
helpful in that?
Yeah, so basically what we call systems biology. So from the genetics to the RNA expression to the metabolites present, if we want to build a bridge, there in such situations we can use AI.
Okay. So you'll be
Uh,
helpful in that because we are doing that.
Yeah, that is what I'm saying.
Okay. Thank you. It was a good talk.
Thank you.
and Dr. Shabir has requested you to share some articles for this group for us to learn. And Dr. Urmila Dhakkar, she said that it was a good presentation, but very difficult to understand. Yes, it was difficult to understand. I also could gather certain things, but probably more we try to learn AI. I think this is the era of AI, and we need to learn on it, learn about AI to be in
Yes.
terms with the newer generation.
So I gave the disclaimer at the beginning, I'm not the expert.
You are not
So
the
my
expert, but still you know a lot. We are still lagging behind.
no, I tried to show you a glimpse. What is a transformer? What are hidden layers? So people know or what is basically what is the difference between machine learning vis-a-vis deep learning. I hope people have understood that that much concept is okay.
Yes,
Uh,
that
we
was
That's
may
clear.
we need not go into what is classifier, what is regression. That is mostly statistics and mathematics.
There's one more comment from Dr. Parthiva Sethi. Says that it was a great presentation. How to generate the model for this type of diagnostic algorithm that you have used for RA trials?
So as I have said, the ILD thing we made our
No, no,
own.
no, not
No,
ILD,
no, no.
RA
I'm
trials.
just I'm explaining that ILD. We made our own model. We trained the model from scratch, and by the time we finished that, we realized that LLMs are much more powerful. You have so many LLMs freely available. You can go to Gemini, you can go to Grok, and they are doing better than any of the models because they have already been trained from terabytes of exabytes of data from across the internet. So for the AI work, the rheumatoid arthritis work, we use already available LLMs. So as I showed you, we use Gwen, we use DeepSeek, we use Gemini 2 versions, and we just use a agentic framework. As I said, one single agent, dual agent, and triple agent, and try to see which agentic framework, which LLM is working best.
So, Sakir, I just want to know like how your journey with the AI started and what intrigued you like into this because this is a very new concept and I think last 2 3 years people are working on AI and we were having a lot of presentations that soon the AI will take over and this is I think five
It will
years back 5 years back like I attended one of the conference where this kind of talk was there and people were very excited because we I think most of the people like we have the basic knowledge of computers and we are just managing our work like with the emails and how a normal doctor like our age group people are working and the our older generation they don't have that also like isn't it so how was your journey how you started and so that at least people will know like how to go about it like it is not one day work it is I think years together you have given to it and that's why you are now understanding how it is all going about.
So, two things here. First, I would say necessity is the mother of invention. So, because I wanted to do this research, suppose in metagenomics, gut microbiota, and I did not have enough funding for a bioinformatics person or to get it outsourced. So I had to learn to do it myself. First, in during my DM, I did some basic work with the metabolomics. Then I took it to the next level. I learned the analysis for metagenomics. Then just learning and obviously as second thing I wanted to say is that what did the AI people do? They scanned the human brain. They found out that the brain works by the neural networks, and they tried copied the neural network, and now they are trying to take over. So as doctors, we should also know what they are doing, and we should not give up our domain expertise, or otherwise they will come and say doctors are useless. We can give you better diagnosis. So uh, this talk will always go on who will replace who. But what I feel is that all doctors, all physicians, all professionals must understand the basics of AI. You may not know coding. That is not necessary. You nowadays you can just tell an agent, I want to do this, tell me the code. So that is how my journey has started. Initially, I started learning little bit of statistics. Then I went into something called R environment, where I used to do my analysis. Nowadays, things are so simple. If you want a code, you just go to Gemini. I want to do this, give me the code. It will give you the code. So in last 6 months, I have installed Python. So Python is something where you suppose the browser, Chrome browser is written in Python. Most of the internet works on Python. So I thought if I can learn R, why can't I use Python? I don't have to do much. All I have to do is I tell Gemini, give me the code, how to do this. It gives me the code, and I have set up a local LLM on my laptop. So if I want to analyze my data, I will not send it to the cloud because any data I'm sending to the cloud, the model learns and it becomes stronger. And patient data, technically, I should not be sharing in the cloud. So I have set up a local LLM, actually a small language model on my laptop. I can use it to analyze without it leaving my laptop.
So
So
basically,
this
people who are into research and this thing, they must
trial and error,
know.
yeah.
Yeah.
If you have the time, if you have the patience, trial and error. And even if you don't have that much patience, at least understand the concept. So at least you are one step ahead of your neighbor who doesn't know it.
And Dr. Mahabaleshwar is asking, is the meeting transcript any possibility of a Word document?
I think that is for the organizers if they want to make it public.
So I've already recorded it, and if it's anybody required, I can share it. If Shaki
It
does
will be
not
on the
have it.
website. It
Yeah,
will
it
be
will
on
be
the
on the
website.
website. Yeah.
I have no issues. It can be shared.
Okay, fine. So here we come to an end to again a very good session of So Reconnect. And when is the next session, Dr. Kiran?
So next is, I think around 15, 16 June, and Dr. Shiva Challa will be talking about the anterior knee pain, how to evaluate and what all is needed. And maybe he will also put a word that everybody must
Attend the
attend
Sorga.
SoulCon at
Yes.
Hyderabad because they are really making good preparation and it will be a very good learning over there. So, and then the June also, like we are aligned. We have got one person who will be talking about the, intra-articular injections and all, a very senior person. And I'm looking forward for that. And July, तो we all are meeting.
No, it's July end. So we can have a meeting in somewhere in July.
चलो ठीक है जैसा
Okay.
प्रेसिडेंट साहिल भाई कहे.
Okay. So thank you, Sakir, for a wonderful
Okay.
presentation. And thank you all for
Thank
joining
you.
us today. I think it gave us encouragement to get into and start learning at least the basics of AI. Though it found it very difficult, most of us, but still, I think we at least got an encouragement that we must now learn. Uh, so thank you and good night, everybody. Anything else you want to say, Dr. Kiran?
बस शब्बा खैर.
Okay.
Looking
Good night.
forward for all the other meetings.
Yeah. Good
Good
night.
night. Good night.